Hi, no, sure. Assalamu alaikum. My name is Omar. Inshallah, today I'll be going to review the physiology part of week 4, starting with the conductive system of the heart. Then I'll be explaining the physiology lecture about the basics of arrhythmia. Hello. Before starting, we should go over the main properties of the cardiac muscle. First of all, we should know that the cardiac muscle has the ability to beat spontaneously and continuously or regularly. Then it has the ability to transmit an excitation wave. Also, it has the ability to respond to any adequate stimulus. And finally, and the main function of the heart, or the main property of the heart or the cardiac muscle, which is its ability to contract and pump blood to all over the body or the circulatory system. So for our cardiac muscle or the heart to pump all this amount of blood to our circulatory system, it mainly depends on action potential. So we have two main types of action potential that are required for the heart to pump this blood. First, we have the myocardial action potential, and also we have the pacemaker action potential. Starting with the myocardial action potential, the myocardial action potential is mainly divided into 5 phases, starting with phase 0, which is characterized by the opening of the sodium channels. So once these sodium channels gets opened, sodium starts to flow in. Once this sodium starts to flow in, this leads to a rapid upstroke or depolarization. As we can see, it leads to an upstroke. Following that, it's followed by then phase 1, which is characterized by the inactivation of these sodium channels. So these sodium channels becomes inactivated and potassium channels opens. Once this potassium channel opens, the potassium ion starts to flow out, leading to an initial repolarization. Then we have the phase 2. This phase 2 is characterized by the opening of also calcium channels. So once these calcium channels opens, calcium starts to flow in. At the same time, potassium starts to flow out, leading to a plateau phase. Once this plateau phase finish, these calcium channels closes, becomes inactivated, potassium channels keeps flowing out, leading to a repolarization. Then it reaches the resting membrane potential. At the resting membrane potential, these potassium channels close, but it's mainly this resting membrane potential is mainly maintained by the leaky potassium channels and the sodium potassium ATPase. Then going into the second type of action potential, which is the pacemaker action potential. So this action potential mainly has 3 phases instead of 5 phases. So it lacks phase 1 and phase 2, but still has phase 0, 3, and 4. Starting with phase 0, which is known as the slow depolarization or spontaneous depolarization. It's mainly characterized by a unique type of channels, which is funny current sodium channels. So in this phase, the funny current sodium channels, they open. These funny current sodium channels, they cause the flow of sodium in. So sodium flows in, leading to a slow depolarization. And at the end of the phase 4, some calcium channels open. So when calcium channels opens, calcium flows in also. Once they flow in, they reach the threshold. Once they reach this main threshold, L-type calcium channel opens, so more calcium flows in, leading to a depolarization. So after depolarization, what happens? Calcium channels become inactive, they close, then potassium channels opens. Once this potassium channel opens, potassium starts to flow out. When they flow out, they lead to a repolarization, going back into the resting membrane potential. So to compare between these types of action potential, as we can see, this one is made up of 5 phases, while this one is made up of 3 phases. As we can see here, the myocardial action potential at certain point, the charge it's mainly maintained. There is a resting membrane potential that's mainly maintained. While if we look at the pacemaker action potential, we can see that it's continually depolarizing. There's a continuous flow of ions inside and outside. So the main key differences between them is that the pacemaker action potential, they have no resting membrane potential, they keep depolarizing spontaneously, while the myocardial action potential, they have a stable resting membrane potential that is mainly maintained by two types of channels, the leaky potassium channels and the sodium potassium ATPs. If we compare between the phases, as we saw in pacemaker action potential, phase 4 has spontaneous depolarization, while in myocardial action potential it's stable, flat, there's no any depolarization. Phase 0 is characterized by the opening of slow calcium channels, which are the L-type, while the myocardial action potential in the phase 0 they're characterized by the opening of sodium channels. If we looked into the pacemaker, as I said, they lack phase 1 and phase 2, so they lack also the plateau phase, which is essential in myocardial cells because these cells are the ones that these phases are the ones that are responsible for the effective refractory period or refractory period in general. If we saw the pacemaker action potential, they are continuously depolarizing. They have automaticity, they have intrinsic pacemaker activity, while the myocardial action potential they don't. They mainly requires stimulation from the conduction system. So mainly the pacemaker action potential, they are spontaneous. They doesn't need any external they do not require any external stimulation, while the myocardial cells or the myocardial action potential, it mainly depends on the pacemaker action potential. So for the myocardial action potential to occur, there should be a pacemaker action potential. And the main function of the pacemaker cells is mainly to generate the rhythm, to set the heart rate, and the main channels or phase to set the heart rate is the phase 4 and mainly the sodium funny current channels. They are the one responsible to set the heart rate, while the main function of the myocardial cells or the myocardial action potential, it's mainly to generate force to pump blood all over the body. So if we compare between the parts of the pacemaker, we will see that the AV node will have the slowest conduction velocity because it's essential to maintain the plateau phase to have a delay in the AV node. So if we compare the time it takes for impulse to go from SA node to AV node, it takes about 0.03 seconds, while from AV node to the bundle there will be a delay and it takes about 0.13 seconds, so it takes much more time. While from the AV bundles into the Purkinje file it takes 0.03 seconds. So the AV node they have the slowest conduction velocity, while the ones that has the highest conduction velocity or the fastest conduction velocity are the Purkinje fibers. So as we can see that the Purkinje fibers they conduct impulses from here all over here and into the endocardium, that will take only 0.03 seconds, while the AV node to the bundles in a short distance would take about 0.13 seconds, so it would take much more longer time. But the ones that has the highest intrinsic firing rate are the SA node, not the Purkinje fibers. So Purkinje fibers has the highest conduction velocity, while the SA nodes are the ones that has higher intrinsic firing rate. And if you look on the one that has the slowest intrinsic firing rate, it would be the Purkinje fibers. And we have a term which is known as an ectopic pacemaker. So what does ectopic pacemaker means? Mainly if the SA node becomes defective or it stops working, the one that would be working and taking over the function of the SA node is the one that has the second highest intrinsic firing rate, which is the AV node. So the AV node will be the one setting the heart rate, and it will be the one that's taking over. So this is known as an ectopic pacemaker. So what mainly controls the heart rate and regulates the heart rate? Mainly the autonomic nervous system. As we know that the autonomic nervous system is divided into two parts. We have the sympathetic and the parasympathetic autonomic nervous system. So the sympathetic nervous system is responsible for increasing the heart rate. So Once So any sympathetic activation will lead to the stimulation of beta-1 receptors. So what would these beta-1 receptors do? They increase the sodium funny current channel. So as we said, these are the ones that are responsible for setting the heart rate. So once these channels gets activated, uh, the resting membrane potential will become more positive, so it will be easier to fire an action potential. So it will cause more firing of action potentials, leading to increase in heart rate. So they will increase the frequency of SA action potential, leading to increase in heart rate. They will increase the AV conduction velocity, and at the same time, since they increase the heart rate will increase the cardiac contractility. So as we know that an increase in the heart rate will increase the cardiac contractility due to the increase of the influx of calcium. So sympathetic innervation, it's considered to has a positive chronotropic effect, positive dromotropic effect, and positive inotropic effect. While the parasympathetic stimulation might have the opposite effect, because these will decrease the activity of sodium funny current channels, and at the same time they will increase the membrane permeability to potassium. So once they increase the membrane permeability to potassium, more potassium will flow in, leading to a hyperpolarization, so it will be more difficult to fire an action potential. So this will decrease the heart rate, at the same time decrease the AV conduction. So that's it for the conductive system of the heart. Moving on, so we have some questions here, but okay, let's go over them. So what is the ion channels that are mainly responsible for the plateau phase? So as we said, plateau phase occurs in which phase? It occurs in phase 3. Which type of channels are activated in phase 3? It's mainly the L-type calcium channels. So the answer here would be L-type calcium channels. What is the key difference between the action potential of cardiac myocytes and SA node? SA node action potential lacks depolarization. No, both of them has depolarization. There's a plateau phase present in the myocyte action potential. Yes, as we saw, the plateau phase is only present in the myocardial action potential. Myocytes do not have a calcium influx. No, SA node exhibit a prolonged plateau. No, plateau phase only occurs in the myocardial action potential. Why does cardiac muscle not go into tetany like skeletal muscles? Lower calcium requirement? No. Smaller sarcomeres unit? No. Does it have a fewer motor and plates? It's not related. It has a longer refractory period. Yes, it has a longer refractory period, which is mainly produced by the plateau phase. So this plateau phase, as I said, is essential for the refractory period. In case this refractory period was not there, the myocardial or the myocytes, the cardiac myocytes will keep on depolarizing spontaneously, leading to tetany. What portion of the heart normally demonstrates the slowest conduction velocity? So as we said, we have we have the conduction velocity, and we have the intrinsic firing activity, which is also the heart rate. So the ones that has a higher heart rates are SA node, while the ones that has a lower heart rate are the Purkinje fibers. But in terms of conduction velocity, the ones that has the highest conduction velocity are the Purkinje fibers, and the ones that has the slowest conduction velocity are the AV nodes. These are the same ones that cause the delay. So jumping now into the basic mechanisms of arrhythmias. So arrhythmias occurs mainly due to abnormalities in the electric impulse of the myocardium, which might lead to either an increase in the heart rate, decrease in heart rate, or an abnormal heart rate. We have two types of arrhythmias. Arrhythmias can be either bradyarrhythmias or tachyarrhythmias. Bradyarrhythmias occur when the heart rate is more than 60 beats per minute, and it's mainly due to either a sinus node dysfunction or atrioventricular block, or it might be an tachyarrhythmia in which the heart rate goes way more than 100 beats per minute. And tachyarrhythmias can be either classified as supraventricular arrhythmia or ventricular arrhythmias. Supraventricular arrhythmias, they originate between the sinus node and the atrioventricular node, and they mainly occurs in the atrium. While the ventricular arrhythmias, they mainly originate below the atrioventricular node and they occur on the level of the ventricles. So the mechanisms behind the cardiac arrhythmias can be either a problem in the impulse formation or a problem in the impulse conduction. Altered impulse formation can be either due to an alteration in the automaticity of the sinus node or what's known as a triggered activity. So sinus nodes can be altered either when their automaticity increase or decrease. As we said, physiologically, their automaticity increase due to autonomic nervous system activation. Either when the sympathetic gets activated, it leads to an increase in the heart rate and increase in the impulse formation, while when the parasympathetic gets activated, they activate the M2 receptors, which might lead to a decrease in the impulse formation, leading to a decrease in the heart rate. Impulse formation also can be altered due to a triggered activity. So sometimes cardiac tissues or cells get injured, and when they get injured, their membranes become leaky. So this will cause the resting membrane to become less potential, less negative, because some ions will flow in and flow out. So this will alter the resting membrane potential. So they become less negative, and when they become less negative, they are more close to the threshold. Since they are more close to the threshold, they are considered partially depolarized. And under these conditions, any action potential will trigger abnormal depolarization, that is after depolarization, and this will either result in an extra heartbeat or rapid arrhythmias. So we have two types of after depolarization. It's either an early after depolarization or a delayed after depolarization. So, as we said, the mechanisms behind arrhythmias can be either alteration in the impulse formation or the impulse conduction might be altered. So we have two causes of altered impulse conduction. It can be either due to a heart block or a re-entry mechanism. So what mainly happens in a heart block that the impulses, the conduction of the impulses mainly slowed. So as we said, in the pacemaker, the SA node goes from the impulse goes from the SA node to the AV node. There is a bit of a delay, and it goes into the bundle branches, then into the Purkinje fibers. So when the conduction of these impulses gets slowed down, this is known as a heart block. This might lead to a bradycardia or bradyarrhythmias. We have another mechanism which is known as a re-entry mechanism, in which impulses will go into a circuits, into an abnormal circuits. For example, here, if an impulse was here, it will go into an abnormal circuits, leads to spontaneous, faster mode depolarization and continuous depolarization of the surrounding myocytes or cardiac cells. So the impulse will keep going into a circuit, leading to a self-perpetuating circuit of excitation, leads to a frequent depolarization. This will lead to tachyarrhythmias, and this mainly will increase the heart rate. So an example of a re-entries can be either a local or it can be global. So example of local re-entry, mainly local re-entry can occur in any part of the heart, but for example, if it occurs in the AV node. So mainly impulses will, the impulse goes in a one pathway, and then it gets divided into two pathways. So these impulses, once they reach either, they get cancelled, and each one goes into the different pathway on its own. But let's say one pathway was blocked. For example, here the beta pathway was blocked. So impulse will go only in one direction. Then when the goes into two directions, and by the time it reaches the other pathway, this block will be gone, so it will flow in the opposite direction, leading to a re-entry circuit. So this re-entry circuit of depolarization might lead to arrhythmias. So what are mainly the cause of a block, a unidirectional block? So it may occur mostly due to difference in refractory period. So one pathway is not in a refractory period, while the other is in a refractory period. So by the time the impulses reach the second pathway, the refractory period will already be gone. So these circuits are the ones that may lead to uh, tachyarrhythmias. We also has a global another type of reentry, which is a global reentry. So global reentry, a classical example of it, which is Wolff-Parkinson-White syndrome. This type of syndrome occurs due to presence of an abnormal connection between the atrium and the ventricle formed by the bundle of Kent. So we have this type of bundle, which is an accessory pathway. So this accessory pathway allows impulses to go from an SE node directly to the atrium. Once they reach the atrium, they enter directly into the ventricles. They bypass the AV node. The AV node is essential to cause the delay in the plateau phase. So once they bypass the AV node, it will lead to a frequent spontaneous depolarization. The impulse will go way much faster. They will bypass any delay. So that's why when we look at the ECG of the patients with Wolff-Parkinson-White syndrome, they will have a shortened PR interval. So mainly PR intervals are prolonged due to the presence of the AV node that will slow the conduction. So since these AV nodes are bypassed, the impulse will be conducted way faster than it should be. So this will lead to a re-entry circuit. Impulses will keep going in this circuit, leading to a frequent depolarization. So we have another type of syndrome, which is known as a long QT syndrome. From its name, the QT interval is prolonged. It can be either congenital or acquired. So in cases of congenital long QT syndrome, there's a mutation that will affect the potassium channels. So when the potassium channels are affected, it will prolong the QT. And we have another, and also long QT syndrome can be acquired. Most likely due to drugs or medications. The most common ones to cause long QT syndromes are antiarrhythmics. So the same drugs that prevent arrhythmias are the ones that can prolong the QT syndrome, leading to arrhythmias. So let's go over the types of the arrhythmias, starting with the bradyarrhythmias. So as we said, bradyarrhythmias, the heart rate gets less than 60 beats per minute. It can be due to due to a problem in the impulse formation or conduction. So problem in impulse conduction that slows the impulse conduction is known as a heart block. So we have 3 degrees of heart block. We have the first degree heart block, second degree heart block, which is divided into 2 types. We have the Mopitz type 1 and Mopitz type 2, and we have a third degree heart block. For now, you just need to know that the first degree heart block and the Mopitz type 1 heart block, they occur at the level of the atrium. They occur due to problem in the AV node itself. While the Mopitz type 2 heart block and the third degree heart block, they mainly occurs in the ventricle or infranodal, a problem below the AV node. And Mopitz type 2 and third degree heart block, to treat it, usually need to give a pacemaker, while for the first degree heart block and the Mopitz type 1, a pacemaker is not needed, usually just an observation. So jumping into the tachyarrhythmias. Tachyarrhythmias, as we said, can occur as supraventricular or a ventricular arrhythmias. Supraventricular, they mainly occurs at the level of the atrium, or ventricular can be at the level of the ventricles. For the ones that are at the level of the atriums are this paroxysmal supraventricular tachycardia. We have the atrial flutter, in which there will be a consecutive atrial depolarization leading to a sawtooth appearance, P waves. We have also atrial fibrillation, In atrial fibrillation, there will be abnormal increase in the heart rate along with abnormal rhythm. So the rhythm will be irregular. And there will not be any recognizable P waves. Here, all the P waves are non-discrete. For the ventricular arrhythmias, it can be either a ventricular tachycardia, which is just an increase in the heart rate more than 100 beats per minute, or a ventricular fibrillation where the heart rate is increased and the rhythm is abnormal, it's disorganized, and there is no any identifiable waves. And the third type of ventricular arrhythmias, we have the torsades de pointes, which is mainly caused by a long QT syndrome. So these long QT syndrome leads to this condition. In this condition, it is mainly known as also polymorphic ventricular tachycardia, in which the waves are in a shifting sinusoidal waveform. For the physiology part, that's it, and thank you.
So now we are gonna talk about the ECG basics. Today will be me, Mohammed, Tareq with you, or move on. Before starting the actual ECG, we need to know some information. As you know, the electrical impulses in the heart moves from the SA node, which is the pacemaker of the heart, into the AV node, into the bundle of His, from the bundle of His into the bundle branches. We have right bundle branch, a left bundle branch, and from these branches we have some Purkinje fibers going from it. In the ECG, this is what you are gonna see: a lot of P waves, Q waves, R waves, S, T, and as you know, the P waves for atrial depolarization, the QRS complex for the ventricular depolarization, and the T wave for the ventricular repolarization. Other info to know that the SA node will give you a heart rate between 60 and 100 beats per minute, which is important because in the ECG there is a way to know the heart rate from it. And so if the heart rate is slower than 60, the patient has a bradycardia, you can think that the SA node is not working, so the AV node is working, so there might be damage to the SA node, and so on. So you need also to know that the conduction velocity is the slowest in the AV node. This is important because in the ECG there is something called the BQ interval. I mean, between the P and the Q there is a small delay here. This is caused by the AV node. If this space is become a lot bigger or taller, this means that there is a problem in the conduction, and we will know about this later. So the slowed conduction is through the AV node, and this is also helps the ventricles to fill the blood before contracting. Now, before going to the ECG, also you need to know what is the ECG made of, or how you are gonna read it. These boxes can be seen in the ECG. What you need to know is that each small box is 0.04 second, and 5 boxes is 0.2 second. So 5 big boxes will be 1 second. So again, a small box, only one small box will be 0.05 second. 5 boxes will make one big box, which is usually 0.2 seconds. So 5 big boxes will make 1 second. Okay. We'll use this right now to know the heart rate for the patient. So for determining the heart rate, I need to have 2 waves. This is wave number 1, this is wave number 2. We need to look for how many waves between them. I mean, how many big boxes between them. So we have 1 big box, 2 big box, and we have half a box here, and 1 box here. So it's a 3.5 boxes. So for knowing the heart rate, we need to say the heart rate is equal to 300 over n. This n is the number of the big boxes that we calculated, which is 5 small boxes for each 1 box. So 1, 2, and 3, and here is a half, so it's 300 over 3.5. It's slightly maybe 85 beats per minute, and this is normal. So Muhammad, what is this? This is 300, 150, 100. So let's say we have another case where there is another QRS complex like here. The space between this R wave and this R wave is only one box, so it will be 300 over 1 equals to 300 beats per minute. This is abnormal, and this will only be seen in atrial flutter or ventricular tachycardia, which is ventricular fibrillation. So for interpretation of the for the ECG, we need to start with some steps, which is finding the P wave. So first step is to find the P wave in the ECG itself. So here is a P wave. This is a P wave. Here is a QRS complex. Here is a T wave. Here is another P wave, a QRS, and a T wave. So the P waves is present. We call this a regular rate. Okay. Another thing we have is a regular rhythm. We are gonna talk about it right now. For the rhythm, I need to check the number of the boxes between 3 or more QRS complexes. This is the R, this is the R, and here is the R of the QRS complex, of course. I need to see the number of the boxes, if it's the same between them or not. So we have 1, 2, 3.5, 1, 2, 3.5. So it's the same, so it's called regular rhythm. I need to check for the B waves. Is the B waves is there or not? Here's a B wave. Here's a B wave. Also here is a B wave. So it's regular rate. When I see regular rate with regular rhythm, it's a sinus rhythm. It's called a sinus rhythm. Okay? So a P wave is present with a regular rhythm. It's called sinus rhythm. Rarely to happen. We can also have atrial tachycardia and atrial rhythm with it, if there is a abnormality. If there is no P waves and the rhythm is irregular, it's called irregularly or regular. There will be having atrial fibrillation, and I will be discussing this later. Also, there is some other cases where we have a P wave but irregular rhythm, which can be seen in PACs or multifocal atrial tachycardia, or sinus rhythm with AV block. Usually these cases are not gonna come in the exam. You need to concentrate on the AV block and the sinus rhythm. All the important ECGs that will usually come in our exam will be discussed. If you have no P waves and regular rhythm, it can be a hidden P waves, supraventricular tachycardia, or ventricular tachycardia. Third step is to check for the QRS complex. I need to check for the QRS complex. The normal for the QRS complex to be 3 small boxes. 3 small boxes. If it's lower than 3 small boxes, it's called narrow QRS. If it's more than 3, 4, or 5, it's a wide QRS complex. So a narrow QRS complex is 120 milliseconds, which is the same of 0.04 multiplied by 3, which is 0.12, which is the same as 120 milliseconds, meaning 3 small boxes. About lower than 3 small boxes is a narrow QRS complex. This can be seen in a Purkinje fiber system, which is working. That means that the bundle of his is not working and AV is not working, SA node is also not working. If you have a wide QRS complex, it will be most likely a bundle branch block, meaning that we have said that we have SA node into AV node into the bundle of his into the right and left bundle branches. If one of them get blocks, the QRS complex will get wide. And how we are gonna know if it's a right or left bundle branch block, we are gonna know in the ECG. So the QRS interval, as you can see here, this is the QRS. It's 1, 2, 3, 4, and 5. This is 5 boxes. So it's a wide one. Okay, this is for the right bundle branch. For knowing how it's right or left bundle branch, you need to look to leads number V1, V2, V3. If you looked into lead number 2 and you had a wide QRS, please go to V1, 2, and 3. If all the V's 1 and 2 and 3 having a QRS wide and it's only up, it's only going up, so it's a right bundle branch block. If you have a QRS complex in lead 2 which is wide and you are suspecting a right or left bundle branch, please go to the V1, V2, V3 leads on the ECG. If you see that the QRS complex is going down, and the third one is also down, it's a left bundle branch block. Okay. Now we need to check for the intervals. We have the PR interval and the QT interval. The PR interval, it's 5 small boxes or 1 big box. It's prolonged in the AV block. This is what you want to know for now. You can read the rest. For the QT, it can be prolonged with reduced calcium, tetany, numbness, and spasm, which can cause another thing that you took, which is dorsal-diaponte. Also shortened in increasing calcium by causing confusion and constipation. For the ST segments, it's very important to know if they are elevated or not, because elevation or depression may indicate that you have an ischemia, which is a very dangerous thing that you need to suspect or to know on the ECG, and you will know, I will see a lot of ST segment elevations and depression in the emergency department usually. So the ST depression in the subendocardial ischemia and the ST elevation can be seen in the transmural ischemia, which will be discussed in the pathology part. Now we will have some ECGs, and we need to know what type of ECGs are they. Are they normal? A pathology? Which pathology? So let's stay with this. Let's start with the steps we talked about. First of all, we have the presence of the B wave. Here I have a B wave. Here a B wave and another P wave. So P waves are there. Now we need to check for the heart rate. How are we going to check for the heart rate? Between the R of each wave, I need to see if it's regular or not first. So 1 big box, second big box, third 3.5. 1, 2, 3.5. You have 3.5. Both of them are 3.5, so it's regular. You have regular rhythm and regular rate. So now the heart rate is equal to 300 over n. N will be the number of the big boxes. 300 over 3.5, 85 beats per minute. Now I need to check for the QRS complex. Is the QRS complex narrow or wide, or it's normal? The normal is 3 boxes. So 1, 2, 3, it's normal. So normal QRS complex. For the intervals, we need to check for the PR, for the ST, and we need to check for the QT. So there is no ST elevations. How are we going to check for the ST elevation? This is the line of the ECG. Please make a line like that. Here's the ST. Is there any elevations or depressions? There is no, so it's a normal ST. For the BR, you need to check the boxes. That's normal. So everything here can be said that's normal. So it's regular rhythm, a regular rate. So it's a normal sinus rhythm. Now for the next case, let's check for the P waves. As we said, P waves. Here's a B wave. P wave is there. The B wave here before any QRS complex. So it's true. P wave is there. So it's regular. Now let's check if they are regularly or not. So we have 1, 2, 3. Here is a half, here is a half, so 3.5. Also 1, 2, 3, and the one to be here. The ECG here is not written, so I'm gonna assume that the heart rate is normal. But let's say it's check the QRS complex. I know it's not that good photo, but as you can see, it's a 1, 2, 3, 4 boxes. Here, the number of the boxes of the QRS complex is increased. This means that it's wide QRS complex. When you suspect a wide QRS complex, please go to the V1, V2, V3 leads. If all the V1, 2, and 3 from what I see are V1, V2, both of them are wide, and all of them are up, going up, it's a right bundle branch block. For the next case, B waves are there. The rate, we can know it later, but as you can see here, the QRS complex is wide. When it's wide, please check for the V1, V2, and V3. All of them are going down, 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 so it's a left bundle branch block. Now for this case, let's go to lead number 2 again. Let's check for the P waves. Is there any P waves here? There is no P wave. This is a T wave. No P wave. No P wave. No P wave. So this is irregular. Let's check for the rhythm. This is 1 box and half and half. This is 2 boxes. 1 box, 2 boxes, 3 boxes, 3. It's a 1, 2, 3.5, 3.5. Is 1, 2. It's only 2. So the regularity of the rhythm is not the same between any two QRS complexes. So this is irregular rhythm. So when I see no P waves, which means irregular, and irregular rhythm, so it's atrial fibrillation straight up. Atrial fibrillation. Now for the next case, there is nothing here for me to say. You need only to know this pattern. It is called the sawtooth shaped pattern. It's only in atrial flutter. Straight up, when you see anything like that, it's called atrial flutter because of its sawtooth shaped. Okay. Now for this, a very chaotic picture. There is no P waves to see aslan. So straight up, this is a ventricular fibrillation. When all the leads are going up and down like that, it's acting crazy. It's a ventricular fibrillation.